Thank you for this few minutes to give you an update on what we're doing in the aspirin research area, and to give you, first of all, a little bit of back history. I was first introduced to aspirin over 30 years ago, so this has to be a very quick summary. I'm a geneticist, and I became interested in hereditary cancer in the late 1980s. And we were working at that time with teenagers with a condition called familial adenomatous polyposis who get cancer at a very young age. And I met a family where the mother had had her colon removed and her son had no polyps, but both of them had little osteomas or bumps on their forehead, which are an extra colonic feature of the syndrome. So I knew he was going to get polyps, but he hadn't got them yet. And it got me to thinking, could we try something to prevent him getting polyps? Because if we could, that would save him surgery at a young age, but also it would tell us things that might be of interest to the general population, because the gene that's taken out in this condition is the one that classically leads to cancer in the older population. So it gave me the idea of the canaries down the mine. Indeed, this family lived right next to one of our last coal mines, and I went and took a picture of their canary for use in lectures. And that was the beginning of a conversation with my European colleagues to go after funding for what was called a concerted action in polyposis prevention, or CAP. And we were successful, and in 1993, we started recruiting teenagers to receive a couple of aspirins a day and a couple of sachets of resistant starch or fermentable fiber. We based the fiber based on the work of Dennis Burkitt, saying that people on a high fiber diet have less cancer, and the aspirin based on the work of Gabriel Kuhn and colleagues in Melbourne, who'd previously shown that people who were on a lot of aspirin or anti-inflammatories like aspirin tended to get less bowel cancer. And there was a growing body of epidemiological evidence to support that. So we thought, here are two interventions that we can try in what's called a factorial design. So people would get one or both or neither of those interventions. And we were reasonably successful, but teenagers aren't the best people to work with when it comes to taking long-term treatments. And so it was a bit of a struggle, although we did randomize 200 gene carriers, which is still the biggest ever randomization in that condition. But in fact, just as we began that project, which ultimately demonstrated that aspirin reduced the number of big polyps, but we couldn't for sure say that it was preventing polyps overall. But in 1993, we were in the middle of the storm of the discovery of the genes for Lynch syndrome, or hereditary non-polyposis colon cancer. And indeed, it was one of our patients in the northeast of England whose DNA was used by the yeast geneticists to identify that condition, and the first of the 4 genes that underlie it. And so we immediately realized this was a better study population. Here were older people. They didn't get thousands of polyps, but they did get a lot of bowel cancer, around about 2% per annum throughout adulthood. And so we started designing what was to become CAP2 and what became our cancer prevention program. And with Henry Lynch and colleagues from around the world, in what were eventually 43 centers in 16 countries, we got the funding, a lot of support, I should say, from Bayer throughout in providing us with the tablets for randomization and support in packaging, and also funding from Cancer Research UK, the Medical Research Council, the European Union, and local charities. We finally got the show on the road in the late 90s, and we completed our recruitment of just over 1,000 people when we actually had the first of our Insight conferences in Newcastle, the International Society for Gastrointestinal Hereditary Tumours, which we launched in that period. And we've closed the recruitment at that point and then began to follow them for the planned 10-year follow-up, because it was clear from the epidemiology that it took a long time for the aspirin effect to become apparent. When we got to the end of the intervention period in the last of the recruits in 2007-8, we hadn't seen any impact on polyps, and traditional wisdom said it wasn't going to work because if you didn't prevent the polyps, you couldn't prevent the cancer. However, we kept on going, and in 2011, we reported that there was an effect on cancer. And then in 2020, we published the definitive 10-year follow-up on our cohort of patients who'd been randomized and had remained blinded throughout the 10 years of follow-up. What we found was really quite dramatic, and it became even more dramatic because in the UK and in Finland, we have comprehensive cancer registries. So we were able to track all of these patients beyond the 10 years with the permission of the ethics committee to see what happened across in the earliest recruits, nearly up to 20 years. And what we found was that from about 4 years out, the two lines began to diverge, and that whereas there was 2% of cancers in the placebo group per annum, there was only 1% in the aspirin group. So it was statistically significant on what's called intention to treat, and that is the gold standard test for all trials. And it was about a hazard ratio of 0.65, but that doesn't tell the whole story. First of all, because in terms of efficacy, we were most interested in the people who actually took the aspirin for at least 2 years. And that's what's called per protocol analysis. And what we found there was that there was, in fact, an even more dramatic effect with a hazard ratio of 0.56. But hazard ratio is not ideal either, because these people can get colon cancer more than once, and hazard ratio only counts the first cancer. So we did a different analysis called incident rate ratio, and that demonstrated that there was a 50% reduction in colon cancer in these patients who took 2 aspirins a day compared to those who took 2 dummy tablets, which were identical in appearance and flavor because they were enteric coated. And so none of us could know who was on the real treatment. And what that means is that for every 25 people who took part in our trial, we prevented 1 colon cancer over a 2-decade period, which is a dramatically successful effect in comparison to many of our interventions in cancer. Just out of interest, the resistant starch, we expected that to also have an impact on bowel cancer. It didn't. And that might be because the cancers in Lynch syndrome are a minority compared to the common or garden adenoma carcinoma progression. What happens in Lynch syndrome is many of them just appear as cancers. So the diet supplement didn't have an impact on the colon cancer, but surprisingly, in our long-term national study of all of the cancer data, we found that it did impact on our second endpoint, which was the other Lynch syndrome cancers, such as the endometrium, the ovaries, upper GI tract. In fact, the impact on the upper GI tract was dramatic. In the treatment group, there were 5 cancers in that group, and in the placebo group, there were 21, which was a really very highly significant result. But it was so surprising, it's taken us 2 more years to get it published, but it appeared this month in the Cancer Prevention Research Journal of the American Association of Cancer Research. And so I'm pleased to say that was on their front cover. So in fact, both interventions worked, but interestingly, they didn't interact. So the effect on aspirin was exclusively down to the aspirin. It was particularly obvious in people who were obese. And we did a secondary and a genuine secondary analysis there and showed that obese people with this genetic condition are twice as likely to get bowel cancer. And that seemed to be abrogated or reduced significantly by those who were on the aspirin. So we're beginning to see some of the ideas that it might be the inflammatory process that's driving the disease. It might also be that salicylates in the general world are most often found in green plants, and green plants use them as a trigger for programmed cell death or apoptosis. Basically, if a plant gets an infection, it releases salicylate in order to trigger programmed cell death to isolate the infection. And we have indirect and direct evidence that salicylates and aspirin will have a similar impact in the body. And so one of the questions was that maybe people who take aspirin are basically replacing something that we used to have in our diet. When we had a wild diet, we would have got a lot of natural salicylates, which we no longer get in processed food because it doesn't get exposed to infection. So that leads into the question that has very much focused our minds in recent years, because the ASPRI trial showed that giving aspirin to the very old population, like me, over 70 and over, is associated with a lot of side effects, and it doesn't appear to reduce bowel cancer. And indeed, there was some epidemiology from Paganini Hill in the 1990s, which said the same thing. So we've got a mouse model that we've been experimenting with where we've got a conditional knockout, a mitochondrial function. We found that as we get older, our mitochondria, up to 10% of someone at my age, will have lost mitochondrial function in the crypts in their bowel, which are the cells, the stem cells, relining the bowel. The reason that's important is that mitochondria are essential to programmed cell death. So if a stem cell becomes cancerous, the first line of defense becomes less and less efficient. We can't use programmed cell death to kill it. If salicylate is enhancing programmed cell death, then we'd expect it to become less efficient with age because fewer and fewer cells are able to do that process. So that mouse model might help us to better understand, and we're actually demonstrating exactly that. If you take out mitochondrial function, apoptosis is lost. So we're beginning to understand the age-related phenomena, but the key point is, as we get to 70 and above, the benefits of aspirin in cancer prevention seem to decline, whereas the side effects go through the roof as our guts become more sensitive to aspirin. So we now recommend that people stop taking the aspirin when they get to 70. But the good news, of course, is if they've been taking aspirin for 2 or 3 years prior to that, you'll see a benefit lasting for about 15 years or more. So the final point to say is that not content with CAP 1 and CAP 2 in 2014, and again with support from Bayer, we started CAP 3. Influenced by Carlo, the chairman of the advisory committee, with whom I'm part of a research group on aspirin called ASCAP. Carlo has always emphasized that we should be using aspirin twice daily. So our 600 milligram group are taking aspirin 300 milligrams in the morning, 300 milligrams in the afternoon. And they're compared to groups who are either on 300 milligrams once a day or 100 milligrams in the morning. So these three groups, again, blinded, so there's a mixture of real and dummy tablets, were prescribed to take one of the three doses to see whether the benefits of aspirin are only confined to the 600 milligram group, or, as we strongly suspect, will be apparent in the smaller doses as well. So we have 1,869 people recruited from 2014 through to 2019. All of them who have stuck with us have completed their 2 years of blinded treatment, and we've got 500 now through to 5 years. We have about 500 left in who will complete their 3 years of open label aspirin in 2024. At that point, we'll be able to see whether the cancer rate in the 600 milligram group is comparable to the 300 and 100, which will allow us to then reduce the dose of aspirin, if indicated, to a slightly less dangerous dose. Although it has to be said, in the young population, it is rather overstated. Most of the side effects are in the elderly population. And in our CAP2 study, there was no significant difference in significant side effects between the aspirin group and the placebo group. Bearing in mind that 600 milligrams, though commonly now regarded as a big dose, that is a subanalgesic dose. We used to start at 900 milligrams for pain relief back in the early days. The reason for that is probably that younger people are far less sensitive and far less likely to get side effects. And so we are hoping that we can demonstrate that it is acceptable to take a bigger dose, but it may be effective to take rather less. And so we currently recommend 300 milligrams for those who are over 70 kilograms, because the excellent work by Peter Rothman and colleagues and published in 2018 showed that there's clearly a body size factor at play here. And so if you're under 70 kilograms, we recommend 150 milligrams or half an aspirin, or 2 baby aspirins in the UK measurement, and over 70 kilograms, we say 300 milligrams daily. And I'm pleased to say that that's been adopted by our National Institute of Clinical and Healthcare Excellence, and so that is now the guidance that is given to all doctors when managing people with Lynch syndrome. And we are in discussions with our colleagues at Cancer Research UK and elsewhere to see whether we can widen that to a larger group of higher risk people, where the benefits clearly outweigh the costs of taking aspirin. One of the obvious questions is, it's all very well getting recommendations and guidance and so on. Does it make a difference? So I've been part of a national team drawing up a new program for the management of Lynch syndrome. We've got Lynch champions in every multidisciplinary team. We've sent out guidance to all of the cancer networks, or cancer alliances as they're called. And in that, we explicitly state that all people with Lynch syndrome should be advised to take aspirin. We are actually auditing that nationally. We're also working we have a PhD student with colleagues in the South, looking at how we reach out to general practitioners to try and encourage them to prescribe aspirin. And hopefully, the other thing we're doing actually is now able to track people with Lynch syndrome on our national cancer registry, even if they haven't yet had cancer. And so we'll be using that route to see to what extent people are being prescribed aspirin as part of their medical record. So it's still a journey. There's still a lot of pushback on aspirin, as we're all aware, and the ASPRI trial didn't help, but it hasn't stopped people supporting this. And certainly my professional colleagues who deal with Lynch syndrome are all very positive about using aspirin as a cancer preventive agent. So still a lot of research to do, and not slowing down at all, and delighted to carry on in this very important work. And thank you all again for this award. Thank you to Bayer for their 30 years of support in this research, and to our colleagues at Cancer Research UK who've stuck with us through thick and thin. Thank you.